Hello everyone, I am Hassan Ad-Dandan, ICU resident from King Fahad Hospital of the University. Today we will speak about chest tube insertion. The procedure should be explained and consent should be obtained if possible from the patient or their next of kin. You will need the following equipment to perform the procedure: chest tube, antimicrobial scrub, scalpel, forceps, Kelly clamp, sutures, needle holder, suction source, chest tube drainage system, connectors, shoulder roll, monitoring equipment, and local anesthetic agent. The patient then should be positioned either in supine or semi-recumbent position. The ipsilateral arm may be maximally abducted to the side of the patient or positioned behind the head to have an optimal exposure of the insertion site. The ideal location for the insertion of a chest tube is in the triangle of safety. The anatomical region is defined by the lateral border of the pectoralis major anteriorly, the anterior aspect of the latissimus dorsi muscle posteriorly, and the horizontal level of the nipple inferiorly. The triangle of safety lies between the 4th to 5th intercostal spaces in the anterior axillary line. Start landmarking by localizing the clavicle, and next count ribs number as you go down the anterior chest wall. Once the correct intercostal space is found, move your hand laterally towards the anterior axillary line. The incision will be made here. The chest tube will be inserted 1 interspace above this point. Mark the incision spot with a marker or needle cap. Start anesthetizing the area, including the skin, the subcutaneous tissue, and the parietal pleura, and anesthetize the periosteal surface of the rib that lies below the intercostal space where the tube will be inserted. Once the parietal pleura is encountered, a flash of pleural fluid will fill the syringe if fluid is being evacuated. If pneumothorax is being drained, only air may fill the syringe as the needle enters the pleural space. Conduct a timeout to verify the patient's identity, correct site, and correct procedure. Make an incision approximately 1.5 to 2 cm in length above and parallel to the anesthetized rib. Introduce the Kelly clamp into the incision and begin to dissect the subcutaneous tissue in order to reach the intercostal muscles. After dissecting through the subcutaneous tissue, stay on top of the rib to guide the blunt dissection. This will create a diagonal path toward the correct intercostal space. Once sufficient dissection is made, you will reach the parietal pleura. The parietal pleura should be entered over the top of the rib to avoid injury to the neurovascular bundle that lies along the groove at the inferior border of each rib. Introduce the Kelly clamp in a controlled fashion into the pleural cavity using both hands to avoid injury to the lungs. Once inside the pleura, spread the Kelly clamp widely as you withdraw to create sufficient opening for the chest tube to be inserted. Before inserting the chest tube, place your finger into the pleural cavity and move your finger around 360 degrees to confirm the correct location in the pleural space by feeling the lung and making sure there are no adhesions that will get in the way of a successful insertion. Clamp the proximal and distal ends of the chest tube before insertion. The distal clamp will prevent any blood from rushing out before connection to the collection chamber. The proximal clamp will assist in chest tube insertion but might not always be necessary or helpful. Advance the chest tube into the incision and unclamp the chyle, then direct the tube slowly. Either apically for pneumothorax or inferiorly and posteriorly for pleural effusion. Make note of the depth the tube has passed by keeping track of the numerical markings on the side of the tube. Make sure that all drainage holes are inside the chest cavity to provide adequate seal and to prevent leakage. Simple interrupted or mattress sutures are often satisfactory to ensure the stability of the tube and avoid air leak around the tube. The free ends of the sutures are wrapped around the tube and tied multiple times to secure it in place. Once the chest tube has been secured, a petroleum-based gauze dressing should be wound around it. Then apply several pieces of sterile gauze around the tube and secure the site with a pressure dressing. A chest X-ray must be obtained to confirm the placement of the chest tube. The radio-opaque stripes are visible with an interruption indicating the position of the proximal hole. This hole must be within the pleural space, otherwise it is outside the pleural cavity and not draining effectively. This is an indication to change the chest tube altogether. Before unclamping the free end of the chest tube, firmly connect it to the underwater seal. Now unclamp the free end. If fluid is being evacuated, the fluid level in the drainage system will rise. If pneumothorax is being evacuated, air bubbles will appear. Suction is maybe applied if there is persistent pneumothorax despite being underwater seal, or if there is viscous pleural collection that is not draining effectively.